This week I'm going to do what I can to help you master this content, which will plague you for every single day that you practice. Now, I'm kidding about that a little bit, but this is one of those things that frustrate many, many new acute care nurse practitioners because they just don't understand how to do fluid replacement, how to interpret electrolyte abnormalities, and things like that. So we all have experience with hyperkalemia and hypokalemia. That's simple. Sodium, a little more complex, right? So let's go through this so that you get a good idea of how we do it. So we'll start with sodium abnormalities. I took a lot of these slides from Barb, and I don't think she minds. We're going to start by evaluating whether they are hyponatremic. Now, remember, when we're dealing with electrolytes, some of those electrolytes are in the blood, some of them end up in the urine. So we need to figure out what the kidney's role is in all of this. We almost always want to get a urine sodium along with the serum sodium, a serum osmolality, and those things. And of course, we want to evaluate the patient, right? That's important. So we start with an assessment of the serum osmolality, and we determine first whether it's an isotonic, a hypotonic, or hypertonic situation. So for isotonic hyponatremia, this most commonly is pseudo-hyponatremia. The patient is getting an infusion of some isotonic fluid, like glucose, for instance, or sometimes they've had a TERP, and that affects the sodium content of the blood. And so we have to rule out all of those things. Laboratory artifact, real severe hyperlipidemia or hyperproteinemia, isotonic infusions running, all of those things. All right. So in most cases, these patients are asymptomatic. We have to then control the hypersolute to fix this. Now, in hypertonic hyponatremia, this is where the kidney ends up getting rid of too much of the sodium. All right. And that gives us a high osmolality and a low serum sodium. We see this reflected in the urine sodium as well. This happens with severe hyperglycemia and also with TERP and hypertonic solution infusions. And the way we treat this most often, because it's usually hyperglycemia that's the cause, is we fix the hyperglycemia. That's easy enough. Now, what about when it's hypotonic hyponatremia? Well, then we have to go from our table up to this part. And we have three different potential causes. We can have hypovolemic, hypervolemic, or isovolemic or euvolemic hyponatremia. So let's look at these individually. The hypotonic hyponatremia is excess of all body water, and that dilutes the sodium, not all body fluids, but all sodium in the body. And we assess then whether the patient is hypovolemic or hypervolemic, keeping in mind that we have to know whether the fluid is in the interstitial space, in the intravascular space, which or both is the issue. If the patient is hypovolemic, then we have to assess whether it's due to extrarenal salt loss or because of renal salt wasting. Is the patient peeing out too much salt? So here are our choices. We have hypovolemic, and the urine sodium is less than 10. This happens in dehydration, diarrhea, vomiting. You see why we need that urine sodium now? Because this helps define whether it's hypovolemic, it helps define the two kinds of hypovolemic hyponatremia. When the urine is too low, That's usually dehydration or diarrhea, vomiting. When the urine sodium is high, we see that with diuretics, ACE inhibitors, or mineralocorticoid deficiency. All right. So it's important, once again, to get that urine sodium as well. And then, of course, when we have hypervolemic, that's edema, heart failure, severe liver disease that causes ascites, advanced kidney failure, cardiorenal syndrome, all that other jazz. Okay? So let's look now at the algorithm that we have for making this hyponatremia diagnosis. We start with the serum osmolality because remember, the osmolality is a function of the solute of the electrolytes that are dissolved in the blood. All right. So osmolality, if you remember from patho, is mostly about sodium because it's 2 times the sodium plus the BUN divided by, I think, 2.8 plus the glucose divided by 18 plus alcohol, ETOH, divided by, I forget what the number is, but we'll just call it X. All right. So remember that 2 times the sodium means that almost all of this osmolality is sodium. So we can quickly, when we're assessing somebody, quickly look at the sodium and know that that is most of the concentrate or most of the calculation for osmolality. All right. But then if the BUN's really high, then that can add something. And of course, as we said several times before, when the glucose is high, that really changes things, right? That has a bigger impact and adds on to the sodium. But remember, the sodium is 2 times the serum sodium. That's the contribution to the osmolality. So the vast majority of the serum osmolality calculation is the sodium on board. Okay, so let's get back to this and start with our serum osmolality and know whether it's normal or decreased. If it's normal, then usually this is either hyperglycemia or, as we pointed out before, pseudo hyponatremia. Okay? Now, if the serum osmolality is decreased, then we want to check the urine osmolality. And if the urine osmolality is low, then we assume that is, or we know that is salt loss, or they're getting too much hypotonic fluid infusion, or they're drinking way too much. They're taking in too much free water. That all makes sense, right? Now, if the urine osmolality is high, more than 200, then we have to look at the effective arterial blood volume, all right? And that's covered on the next slide. When the urine osmolality is increased, we have to assess the intravascular blood volume. And so we use things like the routine blood work, BUN, crit, creatinine, urine electrolytes, fractional excretion of sodium. We use all of those typical things. We also examine the patient, right? Are they intravascularly dry? What's a good, quick way to figure that out? Orthostatic hypotension, right? We can look at jugular venous distension. That gives us some insight. We can look at skin turgor. Neither of these are great. Neither JVD nor skin turgor is really a terrific way. But when you add it all up, you get the feel of whether they're dry, right? Mucous membrane, sunken eyes, absence or presence of edema, ascites, late inspiratory crackles in the lungs, all that stuff, right? And then, of course, we can do invasive monitoring, which we never do, right? We hardly ever do those things. But once we figure out clinically, we say all that clinical information, the laboratory and the physical findings, that is the clinical information that we need to make this diagnosis. And if the fluid volume intravascularly is normal, then that's typically SIADH or hypothyroidism. So we want to check a TSH and reflex T4. Could be certain drugs that are vasodilators, for instance, and glucocorticoid deficiency. So we want to look at the adrenals as well. Of course, if the blood volume is low, then we want to look at the extracellular volume. And if it's also low, then we think about things like diarrhea and diuretics. And if it's high, then that is edema. All right. So this is how we assess somebody's volume status when they come in and they're hyponatremic, because we have to know what the cause of that hyponatremia is in order to treat it. Makes sense, right? All right, so these slides are stolen from Lori Cox. Again, I don't think she minds, but I made some changes to them just to hammer some points home. And also I incorporated some fairly recent trial data that changed everything. You may notice that now we are using more balanced crystalloid than we ever did before. It used to be very common that we would just use saline in everybody. Now we're using a lot more plasma light and LR. So we'll talk about why that is. All right. So first of all, we pose a question. A 63-year-old man with hypertension, diabetes, atrial fibrillation, my favorite thing, COPD, admitted to the ICU 3 days ago with community-acquired pneumonia. He's intubated, mechanically ventilated on CPAP with pressure support of 12. You're called by the nurse with the following data. He's febrile, tachycardic, tachypnic, blood pressure's on the skinny side with a mean of 52. So which of these things would you do next? Would you put in an art line and measure the stroke volume variation and all that jazz? Would you measure the CVP, and if it's less than 8, give a liter of LR? Would you just bolus him with 500 cc's of saline? Or would you do passive leg raise to assess for fluid responsiveness? These are all methods that I've seen employed. Probably the most common one is this one, right? Let's just give some fluid and see what happens. That's a very common thing. But I think you will learn that this is a terrible way to do it. Nobody wants to put in an art line unless we really need it. But I think you're really going to like this one once you understand why we do it. All right? So just to review, there are 4 phases of IV therapy. We have the rescue phase where it's life-saving. We do that in the first couple of minutes. We give big boluses and we hopefully get a blood pressure back. Then we have the optimization period afterwards where we're trying to get the fluids titrated to the right dose. And then we stabilize people over the coming days, and then hopefully we get them back to euvolemia over the next couple of weeks. So let's look at the makeup of this stuff that we're giving. You're going to order it, so shouldn't you know what's in it? Well, starting with normal saline, this is a pretty decent dose of sodium, right? And a pretty hefty dose of chloride. None of the other electrolytes are in there. The pH is acidemic, or acidic, I should say. And that's kind of what we've been using for a long time. A lot of holes there, though, right? A lot of things we need to fill up. Plasma light gets at it, and so does lactated ringers. They're both similar, so let's just use LR, which is the one I'm most familiar with. It has a better dose of sodium to it, 131. It does have some potassium in it, which is nice because how often do we have people who are hyperkalemic? Not as often, not nearly as often as we have people who are hypokalemic. They can usually use the K. The chloride is a more modest dose as well. We also have some calcium in it and some magnesium in it and some lactate. Now, don't freak out about this. This is not lactic acid kind of lactate. This is sodium lactate, which serves as a buffer to buffer the pH in the blood. All right. So this is all pretty good stuff. Look, it's a little bit closer to our normal pH as well. And we really like lactated ringers. Plasmolite too. Albumin, which is a colloid, not a crystalloid, has a sodium level that's potentially much higher, up to 160. And there's some chloride here and there, but mostly for buffer. And the pH is 7.4. Perfect, right? All right, so let's move on and let's talk about why we do it this way. Well, remember earlier, one of the choices for somebody who's hypotensive in the ICU with an unknown fluid status is to check their CVP. This is why, in case you forget from pathophysiology, this is why we don't use CVP to assess volume status. If we were to use or consider the arteries are a little distensible. If you fill them up, you're going to get a little bit bigger artery at the end of the day. So you can fill it in with the normal amount of fluid, and then if you really pack it in until it's at its fullest, you'll have a little bit more fluid. All right, we're not going to put numbers with it. Until now, we're going to talk about the veins that are 8 times more distensible than the arteries. The same volume of vein is going to hold 8 times as much as the same sized artery. Now, that is distensibility. But now, if we combine the distensibility with the volume that it'll hold, we know that there is about 24 times the capacitance in the veins as there is in the arteries. So this is a terrible thing for us to use to monitor somebody or to assess somebody's volume status. It's part of the bigger picture. It is not to be used by itself. All right. And listen, my background's cardiology. There's nothing I love more than neck veins, right? I'm all about the neck veins, but not as a way to, purely to assess volume status. There's a lot of other stuff that goes into it too. There could be an ASD, there could be severe tricuspid regurgitation, maybe due to pulmonary hypertension. There's 100 reasons that you can have distended neck veins. You have to put the whole picture together, and we never ever use neck veins alone to determine someone's volume status. Okay? This was shown in study after study, and we now have, as part of the surviving sepsis guidelines, to not bother using CVP to make clinical decisions. So, does CVP predict fluid responsiveness? Well, meta-analysis was done. And remember what a meta-analysis is. It's where you take the data from multiple studies, you review the quality of the studies. That's part one, usually a systematic review. And then you take the actual data from the studies, plug it into the computer, turn the crank, and you find out if there's statistical significance and what the effect sizes are, etc. What they discovered from this meta-analysis was that there are no data to support the widespread practice of using CVP to guide fluid therapy. And this approach of fluid resuscitation should be abandoned. I kind of agree. Maybe a better thing to do is passive leg raising. When we put somebody's legs up, that delivers about 200 to 300 cc's of pooled blood back into the heart. Let's use that to figure out what happens when we give extra fluid. This essentially identifies fluid responders. You can look at the article in Chest from 2013 and decide for yourself. But this is a good practice. This is better than any of the other tools that we've discussed so far. Now, remember that a fluid responder doesn't necessarily mean that they need fluid, right? Just like everybody who gets steroid feels better, just like everybody who gets diuretic gets better initially, right? That doesn't mean that they need those things, right? Same with fluid. Same with fluid. Just because they respond doesn't mean that they need fluid. That is a clinical decision. And what is the reason that it's a clinical decision? What could go wrong? Well, there can be too much fluid therapy, right? It can mess up lymphatic flow. You can damage the glycocalyx, which is the interface in the vascular endothelium. And you can end up with a ton of third spacing too. Anybody who's taking care of post-open heart patients, they prime that heart-lung machine with a couple liters of fluid. Where's that stuff end up? In the interstitial space, 100% of the time. We can also see this affect organ dysfunction as well. So we don't want to give more fluid than is needed. This is a little explanation about the endothelial lining. That endothelial lining 25 years ago, we didn't think was a big deal. It was only by accident that we discovered how truly important it is for vasomotion, for blood pressure control, for preventing coronary disease and strokes and all those things. I shouldn't say coronary disease, but heart attacks and strokes and things like that. So this is another reminder of how important that endothelial lining is. And it's the glycocalyx that is the interface involved in fluid homeostasis. Okay? These are more reasons to avoid fluid overload. You can take a look at that. So how do we give fluids when we need to? Well, this table is a super important table. Glenn Whitman wrote this for me a long time ago. And this is one of the top take-homes from that whole project that I have kept with me to this day. And that is that when we give a liter of D5W, right, we only get 80 cc's of volume expansion. Most of that fluid is lost in the interstitium. Makes sense if you understand the mechanism, right? If you understand that it's not concentrated enough with electrolytes to keep them in, it makes sense that that fluid is going to leak out. So it's good for hydrating dehydrated people at the cellular level, but not so good for replacing blood volume and keeping their blood pressure up. Okay? Saline, when we give a liter of saline, we have about 200 to 250 cc's that remains intravascular volume. So 3/4 of what we deliver ends up in the interstitial space or peed out. That's a lot. But it's cheap. It's good for rapid infusion. But a lot of it ends up being third spaced. Contrast that with albumin and these colloids. These colloids, when we give 5% albumin, which is 250 cc's, we get about 200 to 250 cc's of volume expansion. That's pretty good. That's 1-to-1. Check out what happens when we give 25% or salt pore albumin. 50 cc's of that pulls in another 200 or so cc's of water from the interstitial space. And that's because colloids increase the colloid osmotic pressure or the oncotic pressure. Oncotic pressure. And what that pressure does, if you remember, is the oncotic pressure generally made up of generally produced by these giant molecules in the blood. That oncotic pressure is the pressure that acts to hold the fluid inside the vascular space. And so when we give these big chunks of albumin, it pulls in fluid from the interstitium. The downside of this is that in catabolic patients, probably most of our patients in the ICU, trauma patients, surgical patients, people who have been in the medical ICU for a long time, they're usually using the protein that we give them for metabolism. So they get rid of it as soon as we give it to them. It's still useful for shifting fluids around. Okay. Let's talk about the physiologic effects of this cheap stuff, the isotonic saline. Again, it adds about 250 cc's to the plasma volume. It does increase the sodium load. It does increase tonicity, and it promotes sodium retention because it messes with that renin, angiotensin, aldosterone system. So there are hidden dangers that are involved in doing that. One of them is hyperchloremic metabolic acidosis. This happens after large volumes of isotonic saline are given. The plasma bicarbonate levels go down, which lead to acidosis, right? And it may have an effect on coagulation and bleeding, probably because of dilution, right? Dilution. And it also decreases the pH, because remember, the saline has a pH of, what do we say, 5.4? Does that sound right? Something like that. Okay? So hyperchloremic acidosis can lead to acute kidney injury. That can happen because of the decrease in the GFR, decrease in renin activity, vasoconstriction at the afferent arteriole, etc. So with all of those bad things about saline, it stands to reason that since Ringer's solution is better balanced, it's a balanced salt solution, maybe it's better in terms of outcomes. Well, this first came on the scene around the 1880s when Dr. Ringer added potassium and calcium to improve the heart's contractility. Not a lot of data to go along with that, I suspect, but in any case, that's what he did. In the 1930s, then, a guy named Hartman added sodium lactate. Remember, not lactic acid, sodium lactate as a buffer, and we called that lactated Ringers. All right? So the original Ringer solution didn't have the lactate in it. Now it's lactated Ringers because it has sodium lactate in it. That increased lactate level in people with impaired liver clearance can cause problems. So we have to be cautious about that. LR has no significant effect on acid base. Remember, I think it has a pH somewhere around 6.5. It has the lactated or the sodium lactate in it that makes it sort of neutral in that sense. Remember, when we bank blood, we put citrate into that so that it sucks up all the calcium in the blood. Free calcium floating in the blood is part of the clotting cascade. And so when we give the citrate, that sucks up the calcium in the blood and makes the blood not clot in the bag. But if we then give it with lactated Ringers, which has calcium in it, what are we going to do? We're probably going to see the blood clot in the tubing. So that's why we don't do it. We don't give blood products through lactated ringers, only through saline. That's all I want to say about this. Now we can talk about hypertonic saline, and this can be 3% or 7.5% or any number of other concentrations. This is more effective at expanding extracellular volume than the isotonic fluids, right? We give it to shrink the neurocells. We try to make them less edematous, and that pulls the fluid out of the cell into the extracellular space or the interstitial space. There is no survival benefit compared to isotonic crystalloids in trauma or TBI. That's important to know. With the balanced salt solutions like Plasma-Lyte, Normasol, and LR and all those, they contain magnesium. I'm sorry, not LR. They contain magnesium instead of calcium. So that is the difference between Plasma-Lyte and LR. LR has calcium. Plasma-Lyte has magnesium instead. All right. They are both buffered with acetate and gluconate to get the pH balanced. So now you might be asking yourself, do we want to resuscitate patients with regular old saline or balanced crystalloids? Well, in 2018, there was an issue of the New England Journal where they put two articles in there that were related. One was the balanced crystalloid versus saline in critically ill adults, and the other one was balanced crystalloids versus saline in non-critically ill adults. So let's go back to the first one. You can read the conclusions there, but let's look at the forest plot because they're more fun. The forest plot tells the story right here. Now, to read a forest plot, you have to know that the odds ratio of 1 is the dividing line. Everything that ends up to the left of the of the odds ratio line favors balanced crystalloids, and everything to the right favors saline. So now if we look at these things, we'll see, and by the way, in order for it to be statistically significant, I'm just going to erase this all now. In order for it to be statistically significant, this entire thing, the dot and the line, has to be completely either to the left or to the right of the odds ratio line. It can't cross that line. If it does, there's too much uncertainty with that sample, and it falls within that 95% confidence interval, which means that it is not statistically significant. So, medical patients or patients in the medical unit were, it was statistically significant that the balanced crystalloids were better. Also for the neurologic patients, that was better. And if they were septic, and if they did not have traumatic brain injury, and if they had previous renal replacement therapy, like dialysis or renal replacement therapy in the ICU. Each of those subgroups we found that balanced crystalloids were better than saline for them. But look at what we saw overall. Overall, we saw with good statistical significance, right? Good statistical significance if you care about that. That's a whole other discussion. But overall, we saw that in critically ill adults, overall, they did better with balanced crystalloid therapy. Now, let's move on to the non-critically ill adults. And they broke this out into 3 different subgroups. Here they have the mean difference in hospital-free days. Okay, so how well did it improve the length of stay, essentially? They also had a second group with major adverse kidney events within 30 days. And then they had acute kidney injury as another option. So let's look at one at a time. Here we see the overall effect with hospital-free days is negligible. There was no difference between the balanced crystalloid group and the saline group. This does not, none of these things were affected. The hospital-free days were not affected by balanced crystalloids versus saline. Either was fine in non-critically ill adults. For major adverse kidney events, we see that when the emergency department creatinine level was more than 1.5, they did better with balanced crystalloids. The ED bicarb level, when it was less than 20, they did better with balanced crystalloids. When the age was less than 65, when the patient was a medical patient instead of a surgical patient, and when the crystalloid volume was less than 2 liters, those patients all did better in terms of major adverse kidney events than when they got balanced crystalloids versus saline. And that was true all through the groups as well. Okay, so overall, patients did better with crystalloids than saline with regard to the major adverse kidney events at 30 days. Finally, the third group, shown here, looked at acute kidney injury. And for patients who had a creatinine greater than 1.5 in the emergency department, the patients with a chloride level greater than 110 all did better with balanced crystalloids. Nobody in any of these studies did better with saline. No. So now let's look at colloids. Colloids, as I said earlier, are useful because they pull fluid in or hold fluid in the intravascular space, because those proteins are giant molecules and they have a very strong effect on the oncotic pressure. In fact, they are more than 3 times effective than crystalloids for expanding plasma volume, because they pull in some fluid from the extracellular space as well. Couple special considerations for albumin. Remember that salt poor albumin, the 50 cc vial of 25% albumin, moves fluids. It doesn't replace volume. So you put this stuff in, it pulls fluid from the extracellular space or the interstitial space into the intravascular space. That's how that works. It doesn't replace volume. It just makes better use of the volume that is stuck in the interstitial space. Okay? We can use 5% as a resuscitation fluid, but it's so expensive. Nobody does that. All right? So let's talk about resuscitation. The colloids versus crystalloids argument has been worn out over the years, and the SAFE trial done in 2004 was one of the things that did that. You'll see, I showed you how to read forest plots. You'll see that in this randomized controlled trial, which was blinded, patients either got 4% albumin. I don't know where they got that. Like the rest of us have 5% albumin, but whatever. 4% albumin or saline were the two groups. You'll see there's no statistical difference between those groups. They both cross right over the relative risk line. So really no difference, although there was higher mortality in TBI. So the mortality with albumin was higher in patients with traumatic brain injury. Then there was a study called the Crystal trial, where they looked at hypovolemic shock and gave colloid versus crystalloid And here you'll see that there's really no difference either. So the 28-day mortality was similar. 90 days, there was a lower mortality in the colloid group, but it wasn't really statistically significant. And we know that there's no benefit to colloid from this trial. So I ask you, which would you use? Colloid or crystalloid? Colloid's expensive, doesn't seem to have much of a survival benefit. Crystalloid is cheap, and as long as we use balanced crystalloid solutions rather than saline, it seems like they are safe for all comers. So I hope you got something out of that. Listen to it again if you need to. This is really important stuff that you're going to appreciate mastering now when you get out and you see that some of your colleagues have no idea how to manage IVs in patients.